Hello again. So I think we can get started. Um, I'm going to introduce myself again for the people that just arrived. I'm Anna. I'm a physiotherapist from Sensing Future. And today I will be presenting our very special guest, Claudia. So Claudia brings a wealth of expertise in the fields of clinical and research aspects of vestibular rehabilitation. Currently, she serves as a vestibular physical therapist at Garcia da Horta Hospital in Portugal. And Claudia is also pursuing a PhD in neuroscience. So we are excited to learn more from her insights and experiences in these fascinating areas of study. So without further ado, I will give the floor to Claudia. Claudia, welcome.
Hi, Anna. Thank you so much. Thank you so much for the so special presentation. Thank you so much for the invitation from all the Sensi Future crew. You are all very special to me, and I'm really glad that I can make this free webinar for you for you and for all the people that are participating today. So thank you so much. Okay.
Thank you, Claudia. Go.
Okay. So starting, I would like to have a little bit more of interaction. So please be free to do questions, comments in the Q&A area in order for us, to. I think that all the webinars and all of the lectures that normally I would like to present. My special goal is to interact and also to learn with the other clinicians and other colleagues that may work in the same area, because all of us have a really big body of knowledge and it's really important for us to share it. So please be free to do that. So
Claudia, sorry to interrupt, but the mic is off. I don't know if you turned the mic off.
no. Hi.
Now it's okay again. Sorry.
Okay. It's just the last minutes, or you
Yeah,
lost?
just the last seconds. Yes.
Okay. Thank you.
No
So
worries.
I will start again.
Yes,
I will start
feel
again.
free. Bye.
Thank you. So as I was saying, I have no financial disclosure or conflicts of interest with this presented material. So it's all part of my knowledge and all of my background and personal journey. And I would like, so I already have a special presentation from Anna, but I would like just to highlight my journey during the vestibular field or the vestibular rehabilitation. So why this interesting? So I start my bachelor I finished, I'm sorry, in 2004. And then I started to work in a hospital setting with neurological patients. And then I had some questions about balance and how I could improve balance with, different strategies that we have at that point. And then because in my master I start some work with vestibular patients, some vestibular research, and I assist a seminar similar as this one, that one colleague was doing some strategies, some maneuvers, and the patient was really bad after that. And I say, this is really interesting. And so I started to pursue this field, and we start to do this work in the hospital. After that, I felt that I needed to, have more formation, more training. And so because of that, in the United States, they have a very special certification, and I pursued that. Nevertheless, I still remain with some questions regarding neurological patients, so central vestibulopathies. So that's why I enter in my PhD in neuroscience. But as you know, and that's why I like to present this slide, as clinicians, we always have, these big questions, and then we have, to build and build and build and create a simple one. And that's what I'm doing. So I work now, I'm doing my work, and my field of research is in the visual vertigo and the visual dependency, and how these can affect these patients or these persons, and how can we improve them. So a lot of things are there in the literature, but it's not so clear. So with going further, what do you think for you, and I will give you a few minutes to put in the chat or in the Q&A part, what do you think that is visual vertigo? So what is visual vertigo for you? It's a special type of vertigo. It is a dizziness. So it's a feel. What you think, what you feel. I will give you some seconds just to, I know that it's hard for us to have this interaction because I'm not actually seeing you, but at the same point, I would like to, provoke some thought on you. What do you think that is visual vertigo? What is it for you? Okay, let's continue. So I think that all the symptoms and all the things that when we are working with people, right? Because we work with people, we have to listen to the problem or to the symptom from a first person. So let's listen to a few.
Bright lights, shelves that are full of busy and colorful products, even people walking towards me or away from me, and noises that are coming from all kinds of directions can all contribute to making me feel dizzy and lightheaded, nauseous, and extra foggy.
Scanning back and forth, scanning up and down. So it's in both those planes. It's too much.
Now, one thing that I have found that helps me when I'm at the grocery store is to always use a shopping cart. That gives me some extra support.
If I can conquer this, then I feel it's the biggest mountain I would have climbed.
Right.
As you see, it's not easy. So people normally say that when they are in these environments, as you see in the first one, so in the grocery store or with some patterns, as our floor in Portugal is so rich on it, or in a subway or in a train station. So it's really hard for them because visually they have a lot of different cues, and it's hard for them to differentiate what is fixed or what is mobile. Why they have that? That's what we are going to talk about it. So why do they feel this way? One thing that it's really important for us to remember, and Dr. Adolf Bronstein is the pioneer of the description and all of the work that it's done in the literature, in the research about this. So we have to think about the multisensorial integration in balance control. So we know that we have three main systems, right? We have the vestibular system, we have the visual system, and the somatosensory. So all of the receptors that we have in our body, right? So we do know that for our postural control, we work and we relate it in one way. And for the equilibrium, that is our postural control related with the environment, is in a different way. But we need these three buddies, to talk more or less the same language, or to talk between them in order to create a stable response. So when you think about the sensorial motor looping, we need to know where we are, right? So the sensor, to compare and to sort all the sensorial inputs that we have. And it's important for us to understand that it's not only a thing that happens at that point. So we do have a lot of different experience. We have a patrimony of different experience in a motor and a sensorial point of view that give us the cues and the information to compare them while they are happening. So this looping is really important because we know where we are in order to know what we are going to do next. Okay, so this is a thing that is happening all over again. And we know that have a lot of pathways, and this is just a simple schematic way to show it. So the vestibular, visual, and somatosensory systems, they are going to tell us where we are in order to interact correctly with the environment, to have a correct production of movement. I'm sorry. So it depends on the context. It depends if I'm in an environment. So we are visual beings, right? It's true that we need to orientate our posture and we need a lot of somatosensory information for that. But to integrate and to organize our tasks, we do need a lot of our visual system. But how I can know if I'm moving my head, while I'm moving my head and I have all of this movement in my visual field, how I will be able to differentiate if it's the field that it's moving or if it's me. So what happens is that I have a visual vestibular interaction in order to know what is the movement that is coming from me, in order for me to understand what is fixed. So just to give you an idea or an example, every time that we have like a earthquake, so everything starts moving, what we have, the sensation that we have first is a vertigo, because normally our walls or our furniture is not supposed to move, right? So if it moves, it's something that is rare in our body of knowledge in a sensorial point of view. So it's going to depend on the context. So if I'm in an environment like in Lisbon, let me say like that, in Lisbon, in Bairro Alto, that it's dark with a lot of, of uneven surface. So I will have a different integration of the three main systems, right? So for that, I will recruit more maybe my vestibular system, because my visual system is not so sharp. So it's all of these information or context are going to constitute a different challenge for my in multimodal integration in a sensorial point of view. So when I'm doing a loop that I don't, okay, or a mortal that I don't, normally I will have to rely more in other systems than vision, because vision is not going to help me. Okay. So, and what happens when one of these systems fails, or when regarding now what we are talking, our vestibular system fails? So as I told you, we have a group of experience. We have it before. There are storage, and they are going to have a comparison. And when we compare the different, experience, and we think, no, this is completely different, and my hand is supposed to be moving, but it's not moving. Well, how this can happen? For instance, I can have labyrinthitis, or I can have a neuritis, right? And then a neuronitis, sorry. And then I will have an asymmetry. With this asymmetry, we know when we have when we move our head to one side and the other side is not moving, we will have an stimulation and an inhibition, right? So if I have a deficit, a unilateral deficit or an hyperfunction, what is going to happen is that my vestibular system is saying that I'm moving, but my visual system and my somatosensory system are saying the opposites. So that's why, and when it happens in an acute phase, that's why we have a lot of different systems. So this is important for us to understand how it can, create some different impact in impairments in patients. So for that, this is a really, really good paper. I'm not going to talk a lot about the symptoms. I'm going to focus in the visual vertigo. But this is a really good paper for us to understand the vestibular symptoms. Why? Because you know that as pain, the vestibular system, they can have quite a big, spectrum because they are subjective, and we need to help our patients to create a reasoning on their systems. So on their symptoms, I'm sorry. So for that, it's important for us to understand also what is supposed to be a consensus. You know that a consensus is it's a lot of expertise of people that treat this kind of persons. So it's going to help us to understand how to they can describe and they can make a reason again about the symptoms. So talking about specifically of visual vertigo. So visual vertigo, until this article is from 2009. Until 2009, this type of symptom was always have the denomination of visual vertigo. Nowadays, this current denomination is visual induced vertigo or visually induced dizziness. Why? Because it's induced by vision. How that can happen, and what is the definition? The definition, I'm sorry. So when we talk and differentiate vertigo and dizziness, vertigo, as we know, is a sensation of self-motion when the surrounding, or so there is no movement of the person, but they have a sense of self-movement distorting during normal head movement. So the movement, the patient, it's stopped, and he thinks that all the things are turning. Normally, I try to differentiate with the patient if they feel that all of the fields are moving, or if they are moving, or if they are feeling something in their heads, differentiating vertigo and dizziness. So dizziness, it's a sensation that it's more disturbed. It's more wide in a sense. It's defined as the sensation of a disturbed or impaired spatial orientation without, what I told you before, a false or distorted sense of movement. So that's the really that's the definition that it's in the paper, and that's the way that we should, differentiate with the patient. So what is visual vertigo then? And what is this origin? So some patients, some persons normally say that when they are in this type of environments, busy environments with a lot of visual cues and with a lot of moving targets, they feel they are more dizzy, or they feel that the surrounding are moving. So this is moving. So for some patients, they are triggered or disconcerted by certain visual environments. So that's the definition of visual vertigo in the first place. And you may ask why I'm going to talk about visual vertigo if we have a different definition now. Even if we have a different definition, a lot of articles still use this type of denomination. So I felt that was important to talk and to create correlations between the semantic in order for you to know what is written in the literature. So, as I told you, a lot is written, some aspect that can happen in vestibular disorders. So it's defined, as I told you, in some other articles like this one of Seng-Shin in 2018, so 9 years after the other definition, and he also talks about visual vertigo. So there is a vertigo that have origins in the oculomotor part. Okay. So a lot of this is written in these articles. These papers are really good. So having this, what is the hypothesis there is behind this type of symptom? So we have a sensory context. Let me say that I am in a place with a good, a good visual environment, not a lot of visual cues, and I'm perfectly fine. And I have these three sensorial inputs, that are giving me the information for me to have a better and a good output, a good motor output. But imagine that one of them stops, right? And when we talk about one of them, we're talking about the vestibular. It's like I have three friends and one of them fails me. So if he fails, I'm going to rely more where in the other two, right? So what happens, and normally this is a cycle, it's not a thing that happens from day to night. Normally what happens is that the person depends on the visual system because it will shut down in a multimodal integration, or decrease the weight of the vestibular system. And that makes the person organize the postural control and all of the postural organization with the visual field. Okay, and that's what happens when we talk about visual dependence. And I'm going to talk about this also happens in other patients. For instance, patients that have stroke and can have a stroke in the parietal part and then have a sensorial impairment, they will rely in the vision in order to do in the foveal vision, in the focused vision, in order for them, to do the movement, like move the hand. And we know that normally we don't need that, right? We have the information from the somatosensory part of my body schema, and because of that, I'm going to move towards my goal, towards my motor goal. That can be, for instance, grabbing a jar or grabbing a cup. So this is similar here. So what happens is that I don't rely on my vestibular system. I have to grape to my visual field in order to be stable. But that have a cost, right? So I told you before that I can differentiate what is fixed and what is not in my environment with the integration of my vestibular and my visual components. If I only rely in my visual field, what is going to happen is that everything that is moving and not moving, I'm not going to be able to differentiate. And that's the cost, right? So when a person is, for instance, in a subway or it's in a floor that have a lot of patterns, what is going to happen is that they are going to relate themselves with this field, and that's why they feel unsteadiness, dizzy, and also vertigo. Okay, so that's the phenomenon that can occur. Visual dependence is one thing, and visual vertigo it's another. So visual vertigo or visually induced dizziness, vertigo, it's a symptom, right? Visual dependence, it's the phenomenon that it's underlying, this type of symptom, or it's an hypothesis, as I told you. So, for instance, a lot of people go to the beach and they say, normally they tell me that they cannot, be in the edge of the beach because they feel like the waves are going and they are going with the waves. If you're trying to relate yourself, we can do that, all of us. That can happen to us when we are in a car, right? And we have to, and we are in a path that is climbing, right? So what happens is our car is stopped and the other car starts moving. What we think is that we are going back. So why? Because we are relying more in our vision and we don't have the trigger of the vestibular system. But as soon as we trigger the vestibular system and this integration, we know that we are stopped and that the other car is moving, right? So these patients have this mismatch, and that's why they have this type of symptom. So this is the current definition. And it's, as I told you, can be visually induced vertigo. That is a vertigo that is triggered by a large, distorted, complex field or moving visual stimuli. Like, for instance, optokinetical stimulation, it can trigger this kind of symptom. So it's including the relative movement of the visual environment associated with the body movement. Like I told you before, the patient is going to relate himself with the visual field, even when it's moving. So the first conclusion that we already talked, it's a symptom, it's not, well, a syndrome. So as this paper says. So again, visually induced dizziness is the dizziness triggered by all the components that we already talked before. But nevertheless, we have a lot of different terminologies in the literature. So let's talk a little bit about that. So the paper is really good in this matter. Also highlights different words that can appear that have more or less a similar not a similar pathway, but a similar way of describing the same symptom. So visual vertigo, visually induced vertigo, and visually induced dizziness are two different types, right? But sometimes they are, so let me just reformulate that because I think that I was a little bit confusing now. So visual vertigo is one of the symptoms and one of the terminologies that were described in the first way. And then nowadays, as I told you, we have visually induced vertigo and visually induced dizziness. So they are different in a way that one is talking about vertigo, and as I told you that it's different of dizziness. It's also described in the literature visual vestibular mismatch or space and motion discomfort, as you see here. Nevertheless, the space and motion discomfort, it's a kind of a polemic one that some of the authors don't think that it's quite the same thing. Sorry about the word. So different concepts. We are talking about spontaneous vertigo. It's not the same thing. Spontaneous vertigo, it's a vertigo that normally it's associated with other types of triggers or pathologies, as for instance, acute vestibular syndrome that is creating an asymmetry, okay? So visually induced motion sickness, and motion sickness, it's completely a different thing, okay? Oscillopsia, we are going to talk about that in a few minutes. And again, some authors think that it's different, space and motion discomfort. So let's talk about oscillopsia and visual vertigo. So oscillopsia, it's a symptom that is described by the patient that while they are walking, they feel, all of the visual field moving, like in a handicap, right? Or in a GoPro. And that happens because the VOR gain is low, and because of that, they don't stabilize correctly the visual field, okay? So, and then they have an oscillopsia that's completely different of visual vertigo. So visual vertigo is while people are in this type of environments, sorry, let me just do this. While they are in this type of environments, they trigger the vertigo or some dizziness associated, okay? It's different of having a moving field with no sensation, okay? Oscillopsia, it's different of visual vertigo. Oh, sorry. So what is the population that are more sensitive to this type of this type of symptom. So one of them is the persistent perceptual postural dizziness, the triple PD. And the triple PD, we know that have, a cycle, unfortunately, that can create, in a chronic point of view, this type of symptom. So they have a crisis, they have a trigger, right? That can be a vestibular crisis or a panic attack that can create an acute adaptation. Unfortunately, nowadays, when our patients suffer some kind of vestibular deficit or some kind of vestibular syndrome, what happens is that they feel so in danger that normally they don't stimulate themselves, and they feel less understood because not all of them have the correct answer in a healthcare point of view. So sometimes what happens is that they protect themselves, they create strategies, and they don't move. So we know that the vestibular system, it's a experience-dependent system. So we need to have movement in order for the vestibular system to be optimized. So if we don't do that, we are going to create cognitive and behavioral strategies in order to not have the symptom, right? And so this kind of population, what they do, they can create a lot of different strategies as cognitive, as I told you, not moving and creating some fear avoidance beliefs, but also they can create a visual dependence and an overall reliance on the visual system. And because of that, they create the symptom of visual vertigo. It's important to clarify that not all triple PD patients have visual vertigo, but they are more prone to develop. Okay. And also, not all of the people that have visual vertigo have triple PD, because they can have also other conditions that can be more prone to develop this kind of problem. So this is a schematic that helps us to understand a physiopathological context or a physiopathological board or pathway that can lead to the persistent phase of triple PD. So that's why, and it's not for this webinar, but it's important for me to talk about it. It's really important to treat this patient in an early phase, because in an early phase they are more vulnerable. They can have the factors as they are here described: pre-existing anxiety, some beliefs of illness, catastrophic personality that can lead, and that can enhance this predisposition to create the triple PD. So they have a trigger normally that it's a trigger that it's there, so a VPPB or a labyrinthitis, something that create a really an acute phase. Sometimes it's more acute than a chronic one, so the chronic is going to develop after. And so the balance is going to be impaired. And if the balance is impaired, they create, as I told you, all of the strategies. And these strategies, as soon as they move, they feel that they are not safe. They are unsafe in a balanced performance. They are going to create more and more beliefs and more resistance to movement. So if they resist to movement, they are not going to create the correct adaptive strategies. So it's important to understand that we have plasticity, neuroplasticity, but unfortunately it can be adaptive or maladaptive. And when we are talking about maladaptive, is that the person develops strategies that are harmful for him in a functional point of view. You can say some people have developed visual dependence or develop some fixation strategies, and they can leave after. That's true, and that happens. But then that have a cost. Not the cost normally is they cannot do. They have a cognitive weight in order to maintain the balance, right? And they do not recruit the automatic systems or the automatic way to maintain the balance. So that's our goal when we work with this patient in a really early phase. So normally we are talking about early, so it's described also in these papers that the elderly are more prone to that because they have normally a multisystemic problem. People with visual impairments, and that makes sense, right? If the camera is altered, if we are going to have also oculomotor problem, so that can lead to this type of symptom. People, so more, we know that some of us, we have what we call a normal spectrum, right? And we know that some of us are more visual than others. So we can also be more, have a predisposition to create this symptom. Normally unilateral vestibular impairments, and that makes sense, right? Because when we are talking about a bilateral one, they can have symptoms of unbalance and steadiness, but it's not like a vertigo one, because normally the vertigo is created by a big asymmetry. And also people that normally have cognitive behavioral limitation as anxiety, depression, and so on. So that can also be a population that are more prone to this kind of problems. So now let's breathe again, me inclusively. I'm going to just a little bit of water. And let's think again. I'm going to do two questions. The first of one is, do you have some ideas in how to evaluate or diagnose visual vertigo? If you have, can you share it in the Q&A? I will give you some seconds. Okay. So how can we evaluate this, this trick? It's a little bit of a tricky symptom. Okay, let's go. So to clarify and we are going to talk about testing and scales. Scales, they are more subjective, but they can allow us to quantify what the patient feels. But also this type of test, the rodent frame test, was used to study more visual dependency, not quite visual vertigo. As we talk, it's two different things. So visual dependence, it's a phenomenon, and not all of the people, as I have in this slide, not all of the people that have visual dependence developed or feel more like that, feel visual vertigo. So that's why measured in this way, in the subjective visual vertigo test, it's not, it doesn't have a direct correlation with visual vertigo. So normally the person is placed in a line, have this, this rod as you see there, and then they have to indicate where is real vertigo, physical vertigo for them. And then we are going to realize, or are going to compare in order to understand if it is correct or not, or how many degrees of error this patient have. Okay, if you have a big range, it's because we have a visual dependence. So this, just to see, I don't know if I feel that I was not so clear. So this is done with some visual cues that can deorganize a little bit the patient. Okay, so that's why we can see the visual dependence. Some scales. So we have the situational characteristics questionnaire and the Nagata questionnaire that have one dimension only, this last one, because the Nagata questionnaire is a questionnaire for triple PD. So these two questionnaires can help us, and the situational vertigo questionnaire have some context that can trigger or not the symptoms. Have some of them that are visual. So that's why there are two scales that can help to quantify and to identify this type of symptom, sorry. So if we have a patient that doesn't have vertigo in a normal way, in a place that doesn't have any visual environment complexity, if he goes to a supermarket and if he tell us that normally in a subway or with a lot of people in a mall, it's really hard. So it's a situational trigger for the visual vertigo. So these are two scales. Obviously, that these scales and some of the work that is done in the literature demonstrate that we know that this impacts directly other type of dimensions, as we see. So hospital anxiety depression scale for the anxiety and depression, dizziness handicap inventory, or even the MoCA for the cognitive part. So the related symptoms can be evaluated with this. We have also one scale that is directly used for the visual vertigo that was developed from our colleague Dannenbaum. Visual vertigo analog scale. It's a scale that have 9 situations, as you see here. This scale is the Portuguese version. We have it in Portuguese, in Argentina, in France, and I think that in other countries also. And 0 is the best, and 100 is the worst. So it's a pretty good scale in order for us to identify and also to quantify. It also developed a lot of evidence, a lot of body of evidence, even to compare to prove that this scale is it's specific or it can evaluate this type of symptom. And also this type of scale have some work in how to identify the different intensities of visual vertigo and the different impact. Okay, now I'm going to give you a few more minutes to identify ideas in how to treat, because I think that was one of the things that you came here, right? To understand how you can treat these patients. And I'm going to talk really fast because I think that I'm having a problem of time. And I'm going to start about the person. So it's really important for us to have a person-centered health model. So the person have to be in the middle in order for us to create an informed and active choice from the patient. And what we do, and normally to do that, we have to have a clear and objective communication. So when we talk about therapeutic strategies for this kind of symptom, obviously the medication that it's not my body of knowledge, as you know, but there are answers for this in this field, vestibular physiotherapy, and also teaching and some cognitive and behavioral therapy. So education for this type of patient, it's really important because as you see, the behavioral component can play a role in developing this type of symptom. So we can give a generic recommendation, but also we can, quantify and tell them what they have, and in what they have to also have an active response. So in a specific way, we have to be personalized. We have to give them an answer, and we have to give them a specific plan because people are totally different of each other. So vestibular physiotherapy, it's a tool, right? So as all of the other things, all of the other techniques that we have in physiotherapy, we need to understand what it's so behind of all of the patient, of all of the in a holistic point of view, in order for us to work with them. So it's important to know how to evaluate, to treat, but also the results of the treatment can guide us to a better intervention. We have a lot of techniques that can come from a neurosensorial to a neuromotor point of view. And when we talk about neurosensorial, is to create, to recruit specifically the sensorial input, as we can use, for instance, the rotatory share. And when we talk about neuromotor strategies, is working with the output in order to recruit and to optimize the integration in a multimodal point of view. Okay, so when we talk about visual vertigo or visual dependence, one of the techniques that we talk more is optokinetical stimulation. Professor Simon was one of the pioneers using these strategies, and the procedure that he have, it's a little bit different of nowadays we can do in some other authors. So normally the optokinetical stimulator was a device that was in a specific way, and normally the direction is chosen by the therapist. That can also, create and cause a postural deviation. So the patient is immersed in this type of stimuli, and what happens is that triggers the optokinetical nystagmus. And also, what we want is so imagine if the patient is visually dependent, if we put them in a room that it's dark with a lot of dots that are moving, what you think that is going to happen, right? So if he's dependent, he will move with these dots. So what we do here is to try, to give them also some cues, some somatosensory cues, and also some verbal cues, in order for him to understand that he's not moving. So we believe, I say that we believe because we have some field, some body of knowledge in the literature, but not so clear. And we believe that what happens is that we are playing with this sensorial reweight in order to recruit the vestibular weight, and then the other, and then to decrease, the visual input. Oh, sorry. It can be done in a lot of ways. You have apps, you have YouTube videos, you have home DVDs, as some articles that I'm going to talk after, and then you have also the virtual reality. I'm going just to say a few things about the virtual reality and some of these devices. It's not that we cannot use it, but it's not quite sometimes, a functional optokinetical stimulation. That being, we know that we have movement in a horizontal point of view, in a vertical point of view, and that we have adaptness, right, associated. When we do with virtual reality, or when we do in a phone that is this small, I don't know if we are actually immersing the patient in optokinetical field, and that we are creating, the circumvection that we need for them, to create this adaptation. So I'm not saying that it's wrong, not at all. Even we have some literature, some articles that told us that we have actually good results, but nevertheless we have to be careful to apply and to understand how we are doing and how we are customizing this type of treatment to the patient. So PhysioSensing, that is the person that is doing, you know, the person. Sorry, there are the ones that give us the possibility and the opportunity to have this webinar. They also have the possibility of doing optokinetical stimulation at the same time related with a posturography quantitative way. So in that way, we can see if the patient is swaying, how they are swaying, and where we are going to do and when we are going to move the patient towards with the optokinetical stimulation. So reformulating or rephrasing, I'm sorry, we can, at the same time that we are doing the optokinetical stimulation, we can see how it's affecting in the postural sway of the patient with this device. Well, what is the problem about optokinetical stimulation? As you see, we have a little bit of a lack of consistency in the protocols and the conditions. It's important to understand dosage. It's important to understand what is complex visual patterns, what is the level of immersion that we need, the frequency, the conditions, the supervision or not, because some of the people can do this direct at home, and we know that the direction and the velocity, it's one of the parameters that we should, you know, customize. So the intensity, a lot of things should be prepared and should be consistent in order for us to have a correct response with optokinetical stimulation, in my point of view. So Maruza Pavlou is one of the authors that did a lot of work in this type of strategy, also with DVDs and other types of stimulation, and she have a good result with this type. She had good results with this type of strategy. So also here, let me just say. Last thing that I want to say, we have a lot of different studies that are trying to understand what is the intensity, what is happening in the brain actually when we are doing optical flow or optokinetical stimulation. So what is happening when we are having actually visual dependence. So a lot of things are being done now in order to clarify better this symptom. I don't know if I have the time, but I will just show you a really quick study case. So this was a female. She had a unilateral vestibular hyperfunction due to a right vestibular neuritis with 2 months of evolution when she came to me. And she was really fixed and really visual dependent. So it's also important for me to say that visual dependence, it's not normally an acute symptom. Normally it's a symptom that develops, okay? And so this was the video that she sent me in the end of the treatment. Oh, I'm sorry. I'm sorry. So she wanted to tell me that she could do Jerusalem. She's a dancer, and she really would like to return to dance. As you see, she still have a little bit of a fixation in her head, but she's more functional now. Okay. So final thoughts. Visual dependence, it's maladaptive due to a vestibular injury also. It can be the origin of the visual vertigo. It's crucial to understand what are the different symptoms in order to understand what the patient is telling us. They are going to describe you a lot of things. You just have to try to make reason about it. Sometimes it's hard and comes with experience. And even with experience, sometimes you cannot do it. But it's important to understand the person. So we treat people. So we need to understand what they are feeling and what is symptom. And sometimes it can be in this type of boxes that we did before. due to this, this component, this cognitive behavioral component, education is crucial with these patients. We really have to change the fear avoidance belief sometimes, and have to tell them that it's normal what they feel, and we have to validate the not only the vestibular symptoms, but also all of the anxiety and all of the other feelings that are having towards their particular situation. So this kind of education, we are not psychologists at all. So it's not bad. We just have to explain them, because the literacy is going to help them to have skills and ways of coping with this kind of situation. So optokinetical stimulation is one of the treatments, and normally is the choice that we use to these conditions. And we do know that we need more body of knowledge to address that. We have a lot to do, but it's still going. So another thought that I want to give you is for all of the vestibular patients. So people with vertigo normally, and with visual vertigo, normally are underestimated. We know that normally they are also underdiagnosed. That's why they develop, because they create strategies of their own, and that impacts a lot in quality of life and functionality. So we need to be interdisciplinary in order to understand better from all the angles and to give the correct response, or the better response, or the optimized response to this patient. So as is multifactorial approach, as is described in the literature, it should be based and centered in the patient, okay? It's important to empower them, not only treat them. So, and with that, I struggled with self-doubt all the time, but I also know that what I know sometimes can help and can be shareable also to others. And I hope that I could give you a little bit of body of knowledge about this, or be a little bit thought provocative. And I hope that you did like it. I would like to acknowledge all of these people, because without them, I wouldn't be here. And I say thank you and obrigada to all of you that are coming from all of the world to see me. Thank you.
Thank you so much, Claudia. That was an amazing presentation. I have learned a lot. I had a lot of questions about this topic, and it was without no doubt a valuable contribution to better understanding of visual vertigo, and how to assess it, and how to recognize it, and how we can treat it and help the patients that we work with. I also want to thank our participants, to all of you, for being here and for listening to this amazing presentation. We are going to release another webinar in the future, but until then, you can stay keep attentive to our networks for other release of other contents. We have Instagram, LinkedIn, YouTube also, and Facebook. The session, I think it's going to be released on YouTube, so it's going to be available for rewatching it. And yeah, so any questions that you have, any other problems, any other doubts, you can just send us an email, or send Claudia an email. And I think she will be glad to help and to answer your questions. So thank you very much for being here.
Thank you.
Thank you.
Thank you.